Good morning, everyone. Morning. My name's Maria Higson. I'm a research fellow here at the Centre for Policy Studies. I am so thrilled that you are all here for what I hope will be a really brilliant panel first thing this morning on the second day of conference. Before we begin, just a little bit of housekeeping. If you do have your phone, please do put it on silent. And we will be moving to questions in the second half of this panel. So please do get your questions ready, and we do ask that you keep them pithy so that we can fit as many in as possible. So the NHS is talked about in something akin to religious fervour. And yet a recent study showed that only about a fifth of people in Britain are actually happy with the way it's being run, with key issues being waiting times for A&E, for hospital appointments, and for those tricky GP appointments. And the Conservatives cannot afford to ignore this issue. The health is consistently one of the top 3 issues for voters. Labour have set out, to some extent, their plan in the NHS 10-year plan, and we may get into what it does and doesn't contain in this panel. But the Conservatives, I think it's fair to say, have traditionally struggled to set out a truly reforming agenda, instead tending to rely on inputs: more doctors, more nurses, more money. So how can we create a credible yet bold vision on the right? We've got a fantastic panel here with us today, and thank you so much, all of you, for joining. So we have here Fergus Cameron-Watt, Associate Director at Global Counsel, a former Special Advisor and with special interest in AI and technology. Next to him we have Joe Robertson, MP for the Isle of Wight East, a member of the Health and Social Care Select Committee and formerly worked for Dementia UK. Then we have Ed Davies, Research Director at the Centre for Social Justice, another former advisor, but also a former journalist and editor, which I think gives a bit of a different perspective. And last but by no means least, Sarah Woolner, Chief Executive at the King's Fund, with frankly a plethora of experience across different charities. So I'm going to start with the same question to each of you, and Sarah, I'm going to come to you first if that's okay. And the question is, how can Conservatives rebuild credibility in health? And how can we get to a reforming vision that goes beyond simply more money?
Thank you very much. I'm delighted to be here this morning. So I'm going to say something to set the scene and then make 4 brief points. Firstly, to build on what you were saying, Maria, the context is pretty stark. So something that we do every year is measure public satisfaction with the NHS. We've been doing so for about 44 years now, and it has never been as low as it is now. Only 21% of people report being satisfied with the way the NHS works today. It's even lower for social care, about 13% of people saying they're satisfied. Importantly, it's not a patient experience measure. Once people get in to receive treatment, they're often reporting much higher levels of satisfaction, but this is a measure of how people feel about the NHS, so it will be partly informed by experience, but partly what they read in the media, talking to friends and family, and so on. It has collapsed, so since 2010, when people reported 70% satisfaction, we have seen a collapse, and it's accelerated through COVID. So, I mean, it's partly, you know, the NHS is always an issue that touches public consciousness, but because there's this huge swell of discontent, disquiet, it feels particularly sort of lively at the moment. So what could a Conservative administration do about it? Well, I think the first thing is to listen to what that survey and various other pollings and so on are telling us. And they are telling us that people don't think the NHS is working in the most basic ways. So when you dig beneath that headline measure, people report concern about getting access to primary care, concern that they're going to have to wait too long in A&E, concern for planned care. So the kind of Ronsil, you know, I want the NHS to be there because support for the founding principles overall remains strong, but I don't think it's working for me, and I'm scared the ambulance won't come. I'm scared my relative's going to have to stay on a hard bench in A&E for hours and hours. So I think there is something about engaging with the kind of here and now and absolutely showing that, you know, there's a recognition it's not good enough, it's a disgrace, lots of people are not getting the care and support and access they need, and that absolutely has to be a top priority, point one. Point two, which is perhaps slightly more interesting, I think there should absolutely be a focus on wrapping services around people and patients. So again, we get this from the BSA, but lots of other places. You know, the NHS is too often Kafkaesque to navigate. And like no other service, almost, we interact with in other areas of our life. So we did a piece of research last year on NHS admin, and people are reporting time and time again letters arriving after the appointment date. My favourite example, a letter addressed to somebody with an appointment for the 99th of January. You know, it's just sort of hopeless, and people phoning telephone numbers and no one answers. So I think there is lots of low-hanging fruit to say we're going to get the NHS working better for you. Now, if you read the government's recently published 10-year plan, there are nods to that. There are nods to, well, we're going to improve the app and we're going to make it easier to access and give you your data. I think there could be a play which is much stronger on everything is about you, your access, ease of navigation, making sure services suit you and wrap around you. And the other reason I say that is increasingly we are living with multiple long-term conditions. Actually, my last job, I ran the National Respiratory Charity, and lots of people living with chronic lung conditions would also be living with, I don't know, a kidney condition or cancer, and they might be caring for somebody with dementia. And the burden of admin and the burden of, you know, having to visit different hospitals, never at a time that suited the individual, was just taking up huge portions of life. So I think there is a very big play to say we are dragging the NHS into the 21st century. We want to make it fit for a 2025 population. We are wrapping services around you. We're putting you in control. Then a couple of last points. There is a lot of consensus in health policy at the moment. We were chatting about this just before we came on. So the 10-year plan the government has published, I mean, it took a year to, you know, develop, but it could have taken 3 weeks in one sense because we've been talking about these themes for many years. So I was thinking, well, how does a Conservative Party set itself apart? I do think there's something about learning from the best in the world, really going out and sourcing other ideas, other solutions. And I give you just one example. We're doing some work at the moment on healthy longevity. You know, we've got an ageing population. Others across the world are further ahead on this demography curve than us. And so we've been learning from Japan, from Sweden. You know, it's not all one way because we're doing some things pretty well. But I think there's something about saying let's learn from and understand good ideas that we could implement here from other parts of the world. Final point, final opening point then, is social care. Now, we are in cross-party talks. We have a Baroness Casey Social Care Commission, and that does complicate matters. But the reality is, I think social care absolutely ticks the box of one of those wicked issues that hasn't been dealt with for decades. We have a broken system. If you look at the data, it's absolutely fascinating. More people, because we've got an ageing population largely, are requesting help and support with social care costs and services. Fewer are receiving it. We don't have the capacity in the system. It's one of these issues where we need a bold, I would argue, solution and a different approach. And I do think there's some policy development, policy work that could be done, which sets the Conservatives apart to say we're up for this challenge. You know, we're going to put forward a bold policy platform to fix social care.
Thank you so much. Ed, did you want to come in?
Yeah, I was just thinking, maybe I should shatter the consensus slightly and say I think Andrew Lansley was right. Not many people in health think that. But taking a step back from the Lansley reforms, which have become this sort of byword for horror, the thing he tried to do was take the NHS out of healthcare. He said, let's give that to NHS England and turn the Department of Health into a Department for Public Health so we can really focus on what makes us healthy. Now, for various reasons, it was horribly managed, it didn't go well, and all the rest of it, and so we're all sort of agreed now that Andrew Lansley got it wrong. But the NHS accounts for about 10% of our health. And I have the great pleasure of a think tank of going to all the party conferences, and I have just been so struck by the conversations are about not what the problem is, but what can government do. And if you take a step back and say, what is the problem here? I think you'll come to a totally different strategy than tinkering with the NHS. So I'm just going to give you 2 pieces of research, both of which have got books written about them, which you should all go away and read. They're probably the 2 biggest pieces of research of the last 20 years. So the first one is the Harvard Study of Adult Development. Are you familiar with this? The Grant Study. It's an 80-year longitudinal study carried out at Harvard University, as the name suggests. And it took a cohort of graduates 80 years ago, which fascinatingly and by total coincidence included JFK. He is one of their cohort. And they have tracked them through their life, and they have tracked 2nd, 3rd, and now even some 4th generation. It's broadened out from just Harvard students now. And they say there is one factor that comes up time and time and time again as the key thing in health. If you want to live a long, happy, healthy life, it is all about the quality of your close relationships. It's more than smoking, more than taking your heart drugs, more than anything else, it is about the quality of your close relationships, okay? The second piece of work, which I think is absolutely seminal in this, you've probably come across the idea of deaths of despair. Any of you heard of Angus Deaton, not the game show host? 2015 Nobel Prize winning economist. His work with his partner Ann Case looked at white working class men in America. And it found in 2015, in fact, a couple of years before that their life expectancy was falling. And he looked at why. What is going on in these people's lives that this particular group is doing very badly? And he came up with this theory, deaths of despair, that these people are basically killing themselves, that the top reason for death for a man under 50 is suicide, as you probably know. But beyond that, you also have cirrhosis of the liver, people drinking themselves to death, you have drug overdose, that actually all the top reasons are people living these terrible, terrible lives. And he describes it in this way, it's a neat way of thinking about it. 50 years ago, if you worked at Trump Tower and you were the night cleaner, you'd come in, you'd meet the other night cleaners, you'd do your job. You might aspire to be the lift man or the receptionist. You might aspire to be the manager of the receptionist. There was a route for you. After you'd done your shift, you would go home, probably statistically, to your wife and 2.4 children where you had some social capital. If you are the night cleaner at Trump Tower now, you are a number on a spreadsheet in a subcontracted organisation. You probably don't have colleagues. If you don't show up, no one cares. They'll go to the next number on the spreadsheet. You have no chance of advancing in your life. And statistically, you will go home, you will probably have 2 children by 2 different women who are now living with somebody else completely. You have no social capital, and you go home and you drink. Because frankly, your life's pretty shit. And I think we have reached this point now where our social contract is so completely shredded in the Western world, it doesn't really matter what the NHS does. Because when I went round the NHS services, when I was in the Department of Health, what I saw in GP surgeries was lonely, isolated people who had nowhere else to go. When I went into A&E departments late at night, what you would see is people with alcohol problems. You would see a mental health crisis in A&E departments. What you wouldn't see is broken arms and cut fingers. I think if we're going to have a strategy in the Conservative Party about health, it needs to slightly forget the NHS and say, what is making us unhealthy? Why is our life expectancy flatlining? And it will come to a totally different conclusion.
Thanks so much. Kind of a really interesting additional kind of lens on this. So Joe, to come to you. So we've heard, I think, a lot about the NHS and some of the problems. And then I think what we've done is then expanded it out and said, well, actually, are we talking about health? Across all of this space, to what extent do the Conservatives, do you think, do we have a credibility in their space? I mean, let's be honest, a lot of these problems, we were in government 14 years, we weren't able to solve. We certainly weren't able to solve some of the problems that Ed talked, those wider social determinants of health. Do we have credibility in this space? And how can we, if we don't, how can we get back into that space where we have something to say to the public that they're listening to in the area of health?
Yeah, by the way, I agree with a lot of what Edward just said, and I'll develop some of those thoughts in a minute. I think as Conservatives, we're far too shy and nervous about talking about health, social care, and particularly the NHS. There's, amongst some of us, not all of us, but amongst some of us, there's a sort of resignation that Labour will always lead on that issue, and it's sort of their topic. And at best, if we can have this sort of score draw on the health debate, that's as good as we can get as Conservatives. I just reject that view. That view has probably prevailed since the NHS was set up, and it's probably been true broadly, but true because we've let it become true by our cautiousness in this area. So that's why I'm really pleased to be here today talking about it. I think 2 features of the health debate in this country, which is kind of quite unique to Britain. One is the politicisation of the health debate, and that is largely because of the NHS. And I agree, that's what Lansley was trying to do, I think. One of many things he was trying to do is take the politics out of it by having the operational control under a new body, NHS England. And we know that that's going to be abolished, is being abolished right now. I think probably the calculation that Wes Streeting has made is, it's all very well having the operational independence of the NHS with NHS England, but the Secretary of State and the government of the day is always going to ultimately take the blame on the performance of the NHS, whether they have direct control of it or not. So he may as well have direct control of it. I suspect that's part of his thinking. And politically, maybe he has a point. Maybe he'll prove to be correct on that, although I suspect he will have long gone by the time NHS England is finally abolished. And I think the second feature is the way we communicate now as politicians, as government, is the headline figure of how much money you're spending on health or the NHS, and the headline figures of how many doctors there are and how many nurses there are just so easy to present, particularly around budget time when the Chancellor's making a budgetary decision. Every single budget will have a health spending decision, will have this headline figure. And as long as the figure sounds massive and the Secretary of State and the Chancellor can sell it, broadly speaking, their calculation will be, and this is on all sides, this isn't about the current Chancellor and Secretary of State, the political calculation will be, the population will be broadly happy that loads of money is being chucked at the NHS. But I think we're at a turning point. I think we're at a turning point that people are becoming, rightly so, more cynical across the whole space of political announcements. That's simply announcing a huge figure which is basically not really referable to anything else. 26 billion extra on health, what does that even mean? And I think most of us are acutely aware that you can keep spending money on an organisation that if it's not working properly, large sums of money get swallowed up. And sorry, there's actually a third feature, I think, for the health debate in this country that's a bit unique. It's the interchanging, and this is to go to what I was saying, the interchanging of the words, or the letters, NHS and healthcare. They're not the same thing. NHS delivers just a part of health in this country, healthcare. Free at the point of use doesn't mean it is NHS delivered. And the best overwhelming everyday example of that is GP practices, right? When people go to see their GP, they will think NHS. And it doesn't matter that they think that. It's free at the point of use. Why do they need to worry too much about how it's funded or how the partnership structure and contracting works that sits behind it? But in terms of a Conservative vision, I think we already have a part of healthcare delivery that works and could work so much better. That is the GP practices. And a lot of what is in the government's 10-year plan is not new. In fact, it's rehashes of previous plans under previous Conservative governments, under New Labour, and going back before that to previous Conservative governments under John Major. The problem has been delivery of really any meaningful element of what is now the 10-year plan. And a tendency to come up, and again, because of the way sort of politics operates within this sphere, to come up with things that probably amount to gimmicks, like the neighbourhood health centres that's in the 10-year health plan. We already have those. They are GP practices, in my view, and they exist everywhere. Everywhere has access to them. They are already in communities. You have far more GP practices than you have hospitals, so they're closer to home by definition. That is where we should be setting out a Conservative vision of delivering more health services through and at GP practices. There has already been a direction of travel in that way. You have to bring the public with you. The times I've heard members of the public say, oh, I went to see my GP and I only saw a nurse. Well, guess what? Nurses are the best people to see if the particular condition or problem you have is a conditional problem that a nurse would ordinarily deal with. You don't need to see a GP necessarily, depending on what problem you've got. who may be overqualified, overstretched, and completely unnecessary. So part of it is about reforming and carrying the public with you, that your local GP practice is not only a place for doctors, but a place for health professionals across the board. That is already happening. We should be supercharging that, not coming up with parallel ideas like neighbourhood health centres, which frankly, even by the government's own ambition, there are only going to be 50 of them by the end of this parliament, which is plainly not national coverage.
Thank you. So I want to pick up slightly, and I'll let you kind of come back on the original question as well, but you said then, this isn't new. A lot of this is about delivery. We've actually, if you look at the NHS 10-year plan, I would agree. I think there's an awful lot in there that we'd all recognise, maybe wrapped in new language, but there's an awful lot of the same. I guess, Fergus, my question to you is really to build on that. Why hasn't this been delivered? What are the barriers? Because it feels very much like we know the challenges, we've known them for a while, and yet we seem to be unable to turn that oil tanker around.
Yeah, I think, okay, I mean, it's nice that you've made all the political points that I wanted to make, so thank you. I guess I'd make one general point on why, and an example why nothing ever changes is, for example, maybe I'll give that kind of departmental perspective, is that on tech spend, for example, something I spend a lot of time now in the private sector working on, is that it's obviously the kind of budget is in year, and it's not ring-fenced. So the minute you have like a massive deficit, and there are trusts running kind of tens of millions of pounds of deficit, what's the first thing that they think about raiding? Is kind of tech spend, and then we all kind of throw our hands up and go, why is it so analog in the NHS? So that's kind of an example of, and I think sometimes it's just about the plumbing. It's one of the kind of core issues. And I guess I make kind of, back to the kind of general point, I make kind of one overarching point and then three specific points. I think the party as a whole needs to kind of agree a kind of a theory of public sector reform. So everyone comes back to kind of Michael Gove going with education, thinking about kind of devolution, but with genuine accountability and autonomy. And that point on accountability, I think, is really key, because I think at the moment we're kind of in a phony war where we think we have accountability over kind of NHS leadership and NHS kind of execs and the ICSs, but I can tell you that the Secretary of State has very little power right now over them. So I guess the second point is on speed. So capital was something that we spent a lot of time thinking about, and how could we speed up delivery of famously the 14 new hospitals. And I think we didn't do a very good story of explaining one of the reasons why 14 hospitals, for example, wasn't delivered in the way that it was promised. And I think, we had in the department, we had a photo in my office of the kind of spend control jumps that every new hospital had to go through, and there were 80 stages, and if you missed one, you had to go back maybe sometimes 2 stages, sometimes 3 stages, and then you would spend, MPs would, like Joe would argue with the department to get sort of lots of money for the enabling works, i.e. the bit to get to where you're putting the kind of shovels in the ground, and sometimes that money would be spent, and then they've missed us, the Treasury says no, we're back to square one, and then they need to go get that more money from the Treasury to do more enabling works. It's slightly madness. So I don't understand why instead of 80 stages there could be 5 stages, and why the CST and the Treasury, Cabinet Office and the Secretary for Health can't have some sort of supra committee to approve kind of capital projects more at greater speed. Because I think I've never met someone who doesn't think a hospital should be built or a GP surgery shouldn't be built. It's not like it's not like housing. It's not something we have kind of same issue with. This won't surprise anyone that I work with, but I kind of obsess about procurement, both when I was in the department but in my job now. And I think the NHS as a whole, to tech suppliers, I'm sure there's lots of suppliers in the room, or kind of medical devices suppliers, it just needs to be a better customer. For example, it needs to have a much more transparent process of who is the decision maker, what are we actually trying to achieve with this goal, not just what we want, but what's the outcome that we're trying to achieve, and being very transparent about that. And when you speak to tech companies, they're very frustrated about the way that kind of procurement is run in the NHS. And then to that point on kind of the use of technology and data, I mean, the fact that I think there's really interesting stat is that everyone thinks there's like 300 data sets in the NHS. No, there's 300 in each hospital, and then another 300 in each ICS, and then you times that, or you cube it. There's hundreds of thousands of data sets. So being more muscular from the department about kind of connecting data sets and kind of that use of technology, and also upgrading basic technology. I think it takes a junior doctor something like 40 minutes a week to turn on their computer. So just a basic investment in technology is kind of important. And finally, I guess I used to be a political advisor. I guess on the politics of this and how the party could credibly do this. I mean, I don't know whether I can challenge you, Joe, on whether a school draw is the best we can hope for, or whether we should aim for higher than a school draw. I mean, it's just very, very hard when you're actually sitting in the department and writing these manifestos, I think. And I think the only way that we could credibly talk about health and kind of reclaim it is by talking about health on our own terms. So if we go in and say, we're going to go cut waiting lists, which we should and should say, obviously, but if that's our lead, we're in trouble because people just won't believe it. Whereas, David Cameron very credibly said, he got it back onto the economy. He said there's no, you don't have an NHS without a strong economy. That worked quite well, I thought, and I think the party needs to kind of tie it back to what is the central kind of sell we're making to the public. So clearly, with Mel Stride as the Shadow Chancellor, we're talking welfare as the kind of key point. So the NHS is clearly built on working people. It's built on people who are working today, who are paying their taxes, and that goes directly into the NHS. And I think we need to make that connection of saying Labour, the inability to solve welfare is directly impacting kind of NHS delivery, and you can get it back onto the kind of core political message.
Thanks so much. So I'm kind of open to anybody who wants to kind of take this on, but we've heard Kafkaesque. We've heard points that I think have genuinely caused ripples of laughter about how it currently works. I think one of the challenges we're going to face, or is one of the challenges, that anything that we say as the Conservatives, we get these attacks from the left, right? It's about privatisation, Save Our NHS comes in. And I guess I wonder, how do we create that clear blue water between ourselves and other parties, which, it doesn't seem to be there at the moment, without reassuring the public rather than inviting in all of those attacks that unfortunately can very quickly sink political careers? If anybody wants to take that on. Joe, maybe?
Yeah, I'm happy to. I think part of it is having a bit of a stomach for it and a backbone and saying we're going to take some attacks from the left, from Labour. Of course. That doesn't mean it's not the right thing to do. So I think part of it is just being a bit sort of resilient about it and being strong. I mean, think of previous leaders, 100 years since Margaret Thatcher was born. I mean, she wouldn't worry too much about whether she was going to get attacked from the left, right? If she thought something was right, she'd drive it through and have self-belief that at the end the plan would come off and, we'd be shown to be right. But just to go back to that point on why has delivery been so bad, because there's been good intentions and good ideas for a long time across different governments, broadly the same principal ideas that are in the 10-year plan. I think part of it is fear, actually. Failure to deliver is fear of disrupting and upsetting certain sectors within health care and social care. And if we look at one of the three left shifts of the 10-year plan, moving from sickness to prevention, right, we all agree with that. We've been trying to do that for years, but progress hasn't been good enough. The sickness bit of healthcare is broadly hospitals. That's where sick people are broadly treated. So if you're moving from allowing people to get sick and then treating them when they are, which is expensive, and bad for people to have to end up in hospital, and refocusing on preventing them getting sick in the first place, so improving public health, that means putting money into, ultimately, public health, not hospitals. But that, unless your budget is going to just balloon, that may mean money coming away from hospitals, which is the NHS. Public health is local authorities, it's the legislative agenda, which may not even be through Department of Health. So whether you agree with it or not, say, ultimately banning smoking by raising the smoking age year on year, whether you agree with it or not, that's an attempt at a public health solution to improve public health, reduce burden on hospitals. If you're going to refocus to public health, the natural consequence must mean one day there will be less money for hospitals because you've reduced sickness, right? And you don't need that hospital capacity. How you translate that into a political message, really difficult. But also, you clearly cannot reduce spending in acute care in hospitals until you've delivered public health outcomes which are medium term at best and probably long term. So there does need to be this sort of potential for additional money going in before you can save. Spending to save, right? It sounds like a sound bite, but there is a genuine element of spending money to save money. So how do you justify the increased cost in order to then ultimately reduce cost in acute care without growing that budget and then one day having to cut that budget back and be the government that's accused of cutting the health budget, when actually what you've done is delivered savings effectively? delivering savings, your opposition will call cuts. And that is really difficult. But the answer is be bold, do it. There's no other option.
Sarah, did you want to come in?
Yeah, I mean, I do think this point around what helps create and sustain good health is really interesting. So lots of figures get bandied around, but, you know, the NHS is only responsible for 10 to 20% of our health. To Ed's point, health is so much more than that. I think that would be such interesting territory for the Conservatives to think about differently. But it's not easy. On the one hand, we've got an existing Labour government who promised in opposition to launch a health mission, which absolutely plays to this health in all policies, essentially, to think about what it takes to create good health. So when we're house building, how do we build healthy communities? How do we encourage strong social relationships, strong social capital? It's essentially disappeared without trace within a year of Labour assuming office. Partly because it's hard to do it, to work across Whitehall and to push that out into the regions in that way. And partly there are so many fires burning, it hasn't sort of risen to be high priority. So I also don't know how naturally conservative some of this is. So if I think about some of the public health measures, like the smoking ban, like, you know, banning junk food advertising, and fair enough, that would only be a bit of it, but there is something about saying if you're having a really bold public health agenda, you've got to be willing to take on some of what creates ill health, and that does involve industries. Now, when we poll, actually, lots of these measures, particularly if you frame them around children and creating healthy environments to bring your children up in, not telling people what to do, just adjusting the conditions, they poll very well. But there isn't as much Conservative heritage of doing this sort of thing. So I think that's a challenge. You know, I think the Conservatives could have a really bold public health agenda. Kind of, are you willing to do what it takes? I just make one other point, which is in our big public satisfaction survey, at the moment, support for the founding principles of the NHS remains incredibly strong. So free at the point of use, taxpayer funded, available for everyone. It's up in the sort of near 90%. Interestingly, it is fraying a bit with younger generations, and the point available to everyone, we have seen a decline. But so I think often where politically Conservatives will run into difficulties, there's suspicion. You know, is there going to be more private sector access? You know, is the NHS, or certainly that's how it's portrayed by Labour, is the NHS really safe in Conservative hands? So there's something about speaking to, if you know 90% of the population support the founding principles, or 90% plus, how do you reassure? And just a related point, which is about data. So, you know, the jewel in the crown of our health and care system in England, in the UK, is our data. This single national health data set is incredibly powerful. I mean, it is brilliant what we can do, because you can track patients, you can follow, you know, from first symptom all the way through to treatment, and we are globally unique in the 60 million population data set that we've got-ish. Now that is very much up for grabs. So on the one hand, the 10-year plan talks about putting data in people's hands, taking on some of the vested interest within the NHS that's prevented people genuinely owning their data. But I think this is an issue that's going to be really lively over the coming years, which is, you know, we don't want our data sold to the States, we don't want our data sold to private companies. We do want our data to be used for brilliant medical research. And so how the Conservatives reassure on that point, because again, there's suspicion and there's anxiety, and that often spills out into public nervousness, I think is worth paying attention to.
We'll just do one final question to Ed and Fergus, and then we'll come out for questions from the audience. So to both of you, feel free to pick up also the data point, but I just want to go back a step. So health in all policies has been mentioned. Ed, you spoke at length about those wider social determinants of health. Are we at risk of finding ourselves in a position where we're arguing for interfering too much in people's lives?
Yeah, 100%. And I think, I mean, the Conservative Party needs to rediscover conservatism and small government. And, you know, my think tank was founded on this really simple sequence. It's called the success sequence, which is finish school, get a job, get married, have kids. Really basic. If you do that, there's a 97% chance you'll never be in poverty. It means you'll have people to look after you in your old age. It means you'll probably never be out of work. Really basic. And it doesn't involve the government at all. And I think we've sort of started thinking of health or education as what can the government do? And if it's not working, can the government do more? When actually, if you don't know your neighbour's names, shame on you. That actually, men, if you're not committing to your girlfriend, commit. Commitment is a good thing. Take some responsibility for your life. And I think those tenets of conservatism are so important, and we've just completely forgotten them. And so all we end up with is, what's the government going to do next? Can we ban this? Can we regulate that? Can we spend more money on that? Well, there's this whole social capital sphere out there that has disappeared. And the thing is, Reform know that. If you go to Reform, I went to a Reform thing on policy. They've got no policy on health, absolutely none. Maybe they'll develop some, maybe they won't. But they've got an absolute laser-like focus on the social contract is broken. And that's why people are going, that's what I see every day. And so they're going over there. And so that's where the Conservatives can steal a march, by being conservative.
Fergus, did you have any final comments?
Yeah, I think on prevention, it's obviously very politically difficult, and whether the party kind of would stomach, I guess, some of the things that we've spoken about today is questionable. On obesity, for example, I saw the modelling on, I think buy one, get one free bans, etc. And I think it was always unconvincing whether the data, for me, it was unconvincing that it would have a kind of dramatic effect on where people get their calories from and whether it would persuade people. So I guess I was slightly unconvinced of that, but I totally agree with Ed on the kind of social contract side of things. That for me, and then my final point, I guess, is the market in many ways is solving obesity. GLP-1s and kind of obesity drugs, obviously they shouldn't be the solution. They should only be used in kind of the right cases and when prescribed. But in many ways, the market has come in and kind of helps the NHS out, and it's about the NHS being a good customer, I guess, of the kind of the providers. I guess finally on the kind of the data point, I totally agree with Sarah. I think maybe where the issues for the party will come, in my view, won't be about kind of selling data, and I think just because I think in a way the public has kind of moved on and they're very comfortable. The polling I saw was that the public are kind of comfortable with their data being used for their own healthcare if it leads to better outcomes. So I think there's quite an easy argument to make. I think the bigger challenge will be on almost like AI ethics, about sort of hallucinations and because this technology, it's very capable, but there's obviously a lot of issues that the kind of the party's going to have to be quite muscular in explaining.
Can I quickly just add on that prevention one? I think there's a very socialist way of doing prevention, which is command, control, ban things. And there is a very conservative way, which goes back to the sort of sense of personal responsibility for your life, including for your health. The more we can create an environment where people feel personal responsibility for their own health, the person that cares most about your own health is you, right? Not someone else. But this idea that health is someone else's problem, it's my doctor's problem, it's my hospital's problem. Actually, prevention is best delivered by having a society where people believe they are responsible for their lives, they take the opportunity, and that includes responsibility for their health, and they themselves will choose to live a healthier life. And that in itself is prevention. That's the best thing you can do to stop yourself getting sick where it's avoidable and ending up in hospital where it's very expensive to treat people.
I'll let Sarah come in very quickly, and then we'll go to this gentleman at the back for a question.
Just very briefly on that, because I don't disagree about, we can't always say it's the doctor's fault or, look to someone else. But if you take obesity, I think this point is worth making. A quarter of 11-year-olds are leaving primary school severely overweight or obese. 60% of the UK population is overweight or obese. There are really deep structural issues at play. It's really difficult for a huge swathe of the population to buy healthy fruit, vegetables, food at the moment with cost of living pressures and so on. And so I just, this idea that it's all about choosing to take responsibility and live a healthy life, structurally around obesity in our food environment, we have a problem. And GLP-1s, of course, they're coming and they're making a massive difference, but you just look at this kind of core base of spiralling downwards children's health, and we're an outlier versus other European countries in terms of our population health. When you pick individual measures, they never make much difference themselves. It's always that kind of comprehensive approach, and so it's are we changing the weather on some of these structural issues? I worry that it's an individual responsibility type approach doesn't cut it, or the evidence suggests it doesn't get to the root of some of what's going on.
Thank you. So we'll go to questions. We have quite a lot, so please do keep them short. We'll start with this gentleman here, and then we'll come down to the front. We'll take 2 at a time, if that's okay. And if I could ask the panel to be relatively short in your answers as well. Thank you.
Thank you. I'm Chandra Kanaganti, a GP and Conservative Counsellor. This is about, thank you, Joe, for saying there are 6,000 neighborhood health centers, which is general practices, and the whole 15 months as a GP are the toughest time ever. And so West Reading keep on bringing online consultation. You can have a no 8 a.m. rush without having any safeguards, without any resource moving at all. Can you do something about challenging this 10-year plan with neighborhood health centers, which will reduce autonomy of general practice and the independent contractor model, which is the reason why general practice survived and sustained in the NHS. And also, he calls GPs as laggards. This is not how you motivate workforce. And the real NHS reform for Tory case is invest where it matters the most. General practice, £1 investment gives you 16 pounds of outcomes. Move the prevention to general practice. We will provide any outcomes that you need, but invest in where it matters the most.
Whilst we get this gentleman a microphone, would anyone like to take the microphone, if we could come down here, please? Would anyone like to take that question whilst we move the microphone?
Yeah, I just agree on that point. I think the problem is with the neighbourhood centres, they're actually going to be disruptive of GP practices and end up having this sort of state intervention that sits outside the GP contract. It's going to complicate it, it's going to make it more challenging for GPs. And there are all sorts of things that haven't been thought through here. So GPs, obviously partnerships with the NHS contract, but also they can sort of own the premises they work from or rent premises. It's a partnership, sort of free market part of healthcare there. These neighbourhood centres, presumably there won't be any borrowing or to sign long-term leases for the buildings, which are very often in GPs' cases provided by third-party landlords, because they'll be state-owned, they'll be NHS, right? And so the money will have to be spent to build or renovate or buy these neighbourhood medical centres. Whereas we have a solution to that within GP practices. The GPs already exist, but they can sign commercial deals with landlords for buildings. That's like a private sector solution. You're going to remove that solution from your neighbourhood medical centres. One tiny example of how's it going to operate, Mr. Streeting. I can guarantee you he hasn't given that the first thought. Not the first thought.
If it's okay, we'll take 2 questions. So take this gentleman and then the lady behind Helen.
Yes, can I, David Campbell-Bannerman, former MEP for the East of England, can I ask the panel what your view is on franchising? Before I was an MEP, I worked for the NHS briefly in interim, and I know some GPs are already franchised in tougher areas. I also went to Hinchingbrooke Hospital, which is run by Circle, which is the only franchise hospital, but it was inspirational. It was choked out by the time by competition, and it was doing so well. I understand that's arguable, but franchising to me is a middle way between the private sector, it uses the private sector skills, without actually flogging off hospitals, which is what the unions tend to object to. Thank you.
If we could take the lady's question as well, and then we'll try and get through as many as possible.
Thank you. I'm Helen Edward, and I'm a governor at a local hospital. My question is, why aren't Conservatives talking about demand and capacity when patients' expectations have grown limitless from IVF to ADHD, autism, and now assisted dying, gender? It's gone too far. We already have models in place on dentistry, on osteopathy, on prescriptions. Why can't we adopt a model where we do some things well and others are independent of what the NHS provides?
Great, thank you. So franchising and then kind of a control of our demand. Anybody want to take either of those?
Yeah, I'm happy to. So I think those are 2 sides of the same coin, basically, because I think until we get control of demand, doesn't really matter if we franchise or not. So I was the US editor for the British Medical Journal for a couple of years during Obamacare. So I lived out in New York and reported on Obamacare, the American system. I then came back and did the Commonwealth Fund, which does international comparisons when I was working at the Health Foundation. And I came away from those few years thinking it doesn't really matter the structure we use. It doesn't matter if we franchise, we could do a Dutch model or an Australian model or a reg. They've all got pros and cons. But if we don't get control of demand, all bets are off. Because actually the problem you're facing in your GP surgery isn't that your GP surgery is trained or you're less well trained as a GP. It's the demand coming through the door. And I suppose that's coming back to my sort of beating this drum of those determinants, those wider things going on in people's lives. Unless we address what's going on outside the surgery and what people think is reasonable, what is a reasonable way to live, it's going to make the jobs of hospitals and general practices completely impossible. And thinking that we can solve that by spending more money on those things is a fool's errand.
Did anyone else want to come in? If we could bring the microphone into the middle aisle, please. So I've got the gentleman third back and then the lady in the striped top behind him, if that's okay, those two.
There's some very powerful points made there, and I thought Joe and Sarah's point about the community service was very interesting, using what we've already got. In Greater Manchester, there's a glaucoma service delivered by local opticians, which cut a waiting list by 72 weeks to 18 weeks. But there's a postcode lottery to that. Building on Joe and Sarah's point, surely it's common sense to use local opticians and audiologists to do even more easy access to GPs and hospitals while improving access to care for patients.
Thank you. And the lady in the striped top.
Thank you, Councillor Gaynor-Signer. I'm a Shadow Executive for Cheshire West and Chester Council. My concerns around overprescription and hoarding, they are linked, and also infections in hospital, which are also linked to overprescription. I just would like to know your views on that situation and maybe how we can improve as Conservatives without it looking like a cut.
Brilliant. Thank you. Did anyone want to take either of those? So we've got use of local opticians and audiologists to model some of the great things that have happened, and over-prescribing, and then link, I suspect, to kind of the superbugs and all of those things. And
Just, I mean, on the kind of using up to, kind of local community services, couldn't agree more. I think one of the best successes we had, at least when I was in the department, was the Pharmacy First scheme, which allowed you to kind of prescribe like kind of prescription of, I think, 7 common conditions, and I think it's even more now, and I think that should be the model that the party goes into in the next election.
Can I build on that? I was going to say something really similar. I mean, I think this is in a way, this is a huge opportunity to, and it's about reorienting pathways of care, using local capacity and resource wherever it is. I was at a community pharmacy meeting last week. Often a community pharmacy will actually be the closest place in a community or from people's houses where they can go and seek medical attention and support. But I wanted to link it back to a point that was made earlier, which is we do have to take the public collectively with us on this. So in my last job, we had a clinical helpline. This was the respiratory charity. The number one reason people called is that they couldn't get access to their GP. And actually, some of that was true. It was the 8 a.m. rush. But when you dug beneath that, some of it was they didn't understand that actually it was the practice nurse that they needed to go and see, or, you know, the pathway had changed and they could access services in a different way. So I wouldn't underestimate the challenge of communicating, look, if you're living with a long-term condition, actually your practice nurse is most expert, or you can access services in the community in a different way. And I think it links to the question about hoarding and overprescription. So I've done some work on antibiotic prescription and how you have a different conversation with people. You do have to invest enough time and capacity in that sort of thing. And I suppose it just makes the broader point, which is actually a lot of how we will deliver things like a hospital to community shift, it isn't the flashy, the glamorous, the headline, the health centre. It's the kind of lower level, slightly duller, not terribly glamorous for politicians to stand up and talk about, but work of redesigning pathways, having different conversations about self-management, because so many people want to be able to self-manage their condition, which plays to the demand point. Investing enough in that, I think, is critical. And I think where the NHS has just been running so hot for the last decade or so, it feels as though some of the capacity to redesign, to push services out in the community has got a bit lost.
If I could have the the gentleman's second back, and then if I could go to this gentleman at the front afterwards.
Thank you very much. Ed, thank you as well for the advice about committing to your girlfriend. I will remember that next time. Next time I'll remember that. But Tom Reynolds from the MDU, and it is for you, Ed, but for the panel as a whole, I was really struck by your comments around the social contract and the breakdown of that. You gave Trump Tower as an example, but you could have easily been describing any NHS hospital. The whole notion of team, of looking after our people, making sure there's a bed for people doing night shifts, making sure there's a canteen for people to get a decent meal, that has just collapsed in the past 20 or 30 years. So I'm wondering whether a niche area for the Conservatives, given that there's been so much talk about pay and rations, that's very important, whether we could lean in a little bit more to looking after our NHS staff, because if they're happy and they're healthy, that will have a positive flow through for everyone. Thank you.
Thank you. And if we could also take this gentleman's question here.
Thanks. Andy from Versus Arthritis, so with the UK's largest arthritis charity. You know, we talked about, Joe and Ed talked about the kind of contradictions between the 10-year plan and also kind of elective recovery plan as well. The biggest single cohort of the NHS backlog is hip and knee replacements, kind of trauma and orthopaedics. The government got some very ambitious targets, and I know a lot of the kind of opposition parties aren't really doing the basics and really holding to the account about the 18 weeks target. So what would like to hear what the panel can do or say about the Conservatives to actually really hold the government's feet to the fire when it comes to their own elective ambitions.
Yes, thank you. Did you want to?
Yeah, quick one of both those. I mean, in terms of holding the government to account, I mean, I'm fortunate I've got one of the two Conservative seats on the Health and Social Care Select Committee. There are 11 members, we've only got 2. That's because of the parliamentary arithmetic, although it's chaired by a Liberal Democrat. But we, as a party, this is sort of practical politics now, we really should use the scrutiny level, not glamorous, not big policy announcements, those must happen as well, but use the organs within Parliament of holding this government to account and not letting people like Wes Streeting, who is a capable politician, a good salesman, get away with just being a capable politician, a good salesman, and not actually delivering on the things he says he's going to do. In terms of motivating the workforce, I mean, that's a massive part of it, isn't it? Whether it's within hospitals, the NHS, or any workforce. I mean, my sister's a nurse, and she's worked across different hospitals, different NHS trusts. And I think what frustrates her is just the difference in the rhetoric of how governments of all colours sort of sell policy around workforce and the reality on the ground, but also the huge difference in working culture between different hospitals and different trusts, according to how much particular pressure there is in a local area or not. And actually, the thing that makes a huge difference to whether a ward or a department or an entire hospital is well run is the actual individuals in leadership roles. And if you've got bad individuals, the department or the ward will be badly run. And if you've got good individuals, the opposite. They need to work, hospitals need to work in the same way that other organisations, businesses work, that failure has consequence. If you are a leader and you fail, you go and you don't get this like NHS thing of you promote the problem. You end up finding a more senior role because they just want to get rid of you, and the easiest way of getting rid of you is to push you upwards where they're not going to get pushback. That is a whole NHS culture thing, which is incredibly hard to turn around, but very significant part of the problem, I think.
Ed, did you want to?
Yeah, very quickly on that point. Firstly, best of luck in all your romantic endeavours. That's what you can say.
Sorry, I should have said that as well.
But it was interesting. So I mentioned I work at the BMJ. Before that, I worked on the GP magazines. They were called things like Pulse and Doctor, very imaginative names. And we do a lot about paying conditions. But when we spoke to junior doctors, sort of quietly behind the scenes, off the record, something that came back a lot was going back 30 years. When you were training, you were part of a firm, and you had a group of doctors around you. You had a senior consultant. You had other junior doctors, and you would cover each other's back. And that was got rid of for good reason, because there was this concern that actually that would mean people covering each other's back and cliques forming, and if you had a bad consultant supervising, you'd be in serious trouble. But with the loss of that, you completely lost that team ethic, and suddenly it moved from being a profession to being a clock in, clock out figure on a spreadsheet. And I think some way of bringing back the firm without the downside would be really important for junior doctor training, and would do a lot for morale.
So we'll take the 2 questions here, and then we'll try and squeeze in the 2 gentlemen at the back there who've had their hands up for this entire time. Your arms must be getting tired.
Thank you. James Gagg, Royal College of Emergency Medicine. I'm a full-time A&E consultant, and it's been fascinating hearing the conversations this morning. Obviously really important that we do build a strategy for all the reasons that you've described over the years ahead. And yeah, as already mentioned a number of times, there's a huge focus on the 10-year plan and what the future should look like. And to touch on what Joe said, there's this, how do you get from that hump from where we are to where we need to be? But my question is, there's an immediate crisis still. I'm not so worried about the 10-year plan. I'm worried about the next 10 weeks. As we head into winter, I've got patients in my corridors already, and colleagues, we've already mentioned about well-being of colleagues and that sort of feeling. 50% of trainees in emergency medicine, for instance, are less than full-time by the time they finish their registrar training because of the burnout. How are we going to have a strategy to deal with the now as well as the strategy for the future?
Thank you. If we could take that question, and as I say, if we could go to the gentleman to the back. Anyone have a final?
Yeah, I mean, I'm happy. I don't have a solution to that, ultimate solution to the question you're asking, but I agree with you. The problem with a 10-year plan is the site sort of, even if it's not the intention, I suspect it might be in part, is it's kicking the can down the road, right? So we've got a great plan of what it's going to look like in 10 years. Meanwhile, we've got crisis right now. That is the problem with 10-year plans, or a plans over a period of time being the sort of flagship, is that's where all the focus goes into how great everything can look in 5 years or 10 years without delivering now.
I think we need to get out of this cycle every year where we get to winter and then it's in at 3 billion is announced to say the NHS over winter. We just need to get out of that cycle. I think one of the ways we need to get out of that cycle is the way we do planning guidance is a completely ridiculous process. You wouldn't run an SME in the way that we run planning guidance, which, if people don't know, is basically how we tell hospitals how much money they're going to have and what they need to do with it. And it's every year it's late. Every year it gets politicised. Every year the Treasury kind of kicks off about it, and that means that hospitals just can't plan for winter. So I just think fixing that maybe is one of the things that we can do to kind of get out of that cycle.
Thank you. So we'll go to the gentleman there, and then the gentleman behind with the beard.
Hi, I'm Ishmael from MainCap Learning Disability Charity. So my question is, how can we make sure there are enough learning disability nurses to support people with learning disabilities with their health needs in the community and support throughout their journey? Thank you.
Thank you so much. And then the gentleman.
So very pithy, but very important. Which countries can we learn from?
Fabulous. Nice, pithy question. Please, does anyone want to?
Yeah, well, learning disabilities community support, if I sort of widen that as well to community mental health, we don't do that particularly well. Our select committee has just done a report into that. But this is something that I think Shadow Chancellor is going to pick up. In fact, he's probably delivering it right now, is this crazy idea of over-diagnosing mental health and then giving people a payment in return. Instead of doing that, redirect that money into better community mental health services for everyone who need to access it, rather than individual personal payments for people who are possibly overdiagnosed or have a issue because the services weren't there in the first place.
I'm so sorry. I'm afraid we are running rather late.
Learning disability and mental health are two different things.
Yeah, I agree with you, but I agree with you. But what you would talk about, I think, also is delivering the community. And again, for learning disabilities, same principle is that people need to be supported, and the money needs to be redirected to support them for the care they need, that they understand, and that they can be then responsible for, and to treat someone with learning disabilities in a way they simply don't understand is not going to sort the underlying condition. And then in terms of which countries can we learn from, I mean, I think that is a whole feature of healthcare. Again, we tend to only think in a sort of our own national environment, where there are hundreds of countries in the world and there are at least dozens who are doing it better than us. So we need to be more, lift our eyes to the horizon and look at other countries, but I don't have a list of countries that do it better than us. What I would say is be slightly careful of pointing to a country with a population of, say, 4 or 5 million. Very, very different delivering healthcare to a population of 4 or 5 million, say, Scandinavian countries, than a country with a population of nearly 70 million.
Sarah, did you want the last word on that one?
Yeah, so 2 quick points. The MenCap question, I think this is brilliant example of we tend to prioritise and focus on what we measure, and we're very good at measuring what happens in acute hospitals, so A&E waits, ambulance waits and so on, and we're far less good at understanding and measuring what's happening in the community, and hence you do get sometimes longer hidden waiting lists for support in the community for learning disabilities and so on. So there's something about a parity of really understanding what's happening, understanding need and demand. The international comparisons question, I think, is a brilliant one. I mean, I think we can learn from lots of different countries and share. And so I mentioned a project we're doing with Japan and Sweden. Maybe to give you one other example, I did some work learning from other countries with similar health systems about how we improve cancer outcomes. In the UK, our cancer outcomes not comparable with some other nations. And then really fascinating to study. And actually, it was a mixture of some Scandinavian, parts of Canada, parts of Australia, similar health systems. One key learning, our GP as gatekeeper system actually for early cancer detection isn't always very good, and what you want to make sure is that you are sending people for referral if there are red flag symptoms as quickly as possible, and actually that has been translated into policy. So community diagnostic centres, this idea of more facilities to carry out tests for potential cancer is happening. So I think we should be much more open, I mean, and people learning from us as well. But I would, that word of caution, you do have to be slightly careful about just simplistic comparisons. And we also have much better data than most other countries in the world at a national population level. So we've just got to be careful we're comparing like with like.
Brilliant, thank you. I am so sorry that we don't have time for any more questions. I will say the Centre for Policy Studies is doing a lot of thinking about health and social care, so please do get in touch, get involved. We are on social media, and please do get in touch via our website where you will find my email address as well. Centre for Policy Studies is running more events. The next one is here at 11:10. I've been told to tell you about it. It does have Dr. Gerard Lyon, who, if you haven't seen before, is absolutely brilliant. So one not to be missed. So the final thing to say is a huge thank you to you all for making it here. And if I could ask you to finish with a big thank you to our panel.